Today, we are talking about something that everyone kind of has some relevance to, which is melanoma, right? Very scary. And yet the treatments for melanoma have changed hugely in the last 10 to 15 years. There is nobody else that I could be more excited to have with us today other than Dr. Keith Flaherty himself. Keith, thank you for being here, and please tell us about yourself. I saw you almost use the term like an old castle in mid-century because there's ivy all over it. And I know you were at UPenn and Harvard and Mass General now. I'm beyond starstruck to have you.
Yeah, thanks, Sanjay. It's a pleasure to talk with you today. So my background is in oncology now is 22 years almost. That's when I finished my medical training up to my oncology training, which is medical oncology fellowship. And then I did that at University of Pennsylvania, and I stayed at University of Pennsylvania for 7 subsequent years, so 9 years in total for the first stint of my career in terms of doing research, which we'll touch on at some point. I refer to that as the decade of the 2000s, not because that was the decade that I was at University of Pennsylvania, but more because that was the first roughly half of my career where we still really had no effective therapies. I mean, we're going to unpack that, I think, a little bit in our discussion, but the turning point came, roughly around 2010, and it was in 2009 actually when I made the transition to Mass General Hospital, which is under the Harvard Medical School umbrella, and have been there now for 12 years. And throughout, I mean, basically, as a medical oncologist, my primary interest going into the field was to really try to understand cancer biology from the perspective of developing new therapies. And my really poorly developed insight coming out of medical training in the decade of the 90s was that if there was any disease state for which molecular insights were accumulating most rapidly, it was cancer. And so, the term that we use in the sort of scientific community is molecular biology, right? Which is really, when we use that term, what we mostly mean is decoding the genome of either disease or healthy tissue, doesn't so much matter. But molecular biology tools were really brought to bear in cancer first and foremost. It was cancer researchers who were the ones who were, in many instances, developing, if not developing, then at least applying those tools in the earliest instance. And so what that meant was in the decade of the 90s, there was just this massive swell of new insights in terms of what I'll call the genetic architecture of cancer. And my naive insight coming out of my medical training years was that, well, this is a building wave, and the wave's going to break. Like at some point, these insights are going to translate into medicine, and I want to be a part of that. So that's how I, kind of approached the field. And I chose to focus on melanoma, largely because so few therapies existed. I mean, it was such a vast unmet need, an aggressive cancer. Certainly when it had spread internally. Very aggressive cancer with hardly anything to point to in terms of effective therapy. And it was one of those areas where I felt like molecular insights were really accumulating substantially, which obviously we can unpack a bit.
And to your point, and that's something that's very important for everyone to understand, is that cancers become cancers by taking tools that all of our regular cells have, and then what have they done to make that tool all of a sudden just make this cell, go unregulated and grow, right? So if you have a bunch of tools to build a house and you're building houses your whole life, a cancer will take and manipulate those tools to say, well, if there's a code, if there's an HOA in this neighborhood, I'm just going to grow this huge, house and continue to grow all over everybody and take over the entire neighborhood. And that's what cancer is. And when you're unpacking it, what you're looking for is, what did they do? Did they all of a sudden get a whole bunch more hammers? Did they all of a sudden just lumber shipments? What is it that I can attack, that I can stop, so that suddenly it does not have the ability to grow, and in an ideal world actually get smaller and be completely restricted and unable to proliferate?
Yeah, well, let me just add a little bit to your starting point here, because what I would say, using your kind of architecture analogy, is think of it this way: that every cell in the body has the same blueprint, has the entire blueprint. Right. For every other cell in the body, okay? Right. But there's no cell in the body that's meant to have all functions, right? I mean, even what we refer to as stem cells, their job is just to spawn kind of the next, lineage, if you will, of cells, but they themselves will actually, circle back, if you will, remain stem cells. But anyway, let me put it this way. A melanocyte, a pigment-producing cell in the skin, which is what gives rise to melanoma, and a cell that lines the lung epithelia that's involved in gas exchange, or a cell, a cardiac myocyte, a cardiac muscle cell. Every one of those cells has the entire blueprint in them, the same genetic code, right? But they're not supposed to be reading that blueprint. They're supposed to be reading one small part of it, right? So imagine that you have the architecture firm has the blueprint for the entire body and its entire cellular composition. But when they're hiring contractors to build individual houses, right, in the neighborhood / the city, they hand them the portion that they need, right, basically, exactly. Right? They read that part. And that's the part that I think really wasn't in view in the beginning of my career, this notion that really what's happening is through the accumulation of genetic alterations as the kind of fundamental component of how cancer becomes, capable of accessing, I think what you referred to, and I like this analogy too, the toolbox. Right. I mean, about accessing what I was just referring to as the blueprint, like figuring out basically a melanocyte, just to get, stick with that example, it migrates from the same cell population that form the neural tissues, I mean, brain cells and other components of the neural system. So the same sort of cells of origin, they migrate away from where the brain and the nervous system are established, and they populate then this layer of the skin, the bottom of the epidermis, or the base of the epidermis as we call it, and they stay there, right, lifelong. And they're very long-lived cells. They're very hardy, long-lived cells. They're not supposed to travel, right? So talk about like a component of the blueprint. They're not supposed to have access to that part of the blueprint. And you might say, well, what cells in the body travel? I mean, beyond development, when a lot of cells are traveling, you readily think of, well, immune cells. I mean, immune cells travel all around the body, right? They go in and out of tissues. There's like almost no place they can't go. And so melanoma cells, and for that matter, lung cancer cells and colon cancer cells, for cancers to travel, nearly all of them have to start reading a component of the blueprint that was not supposed to be open to them, basically. Right. So think of this as kind of a crosstalk between mutations, genetic alterations, which are the fundamental building block, if you will, that results in an opening of this blueprint. And that's when we talk, and as we'll, I think, get to, when we talk about escaping immune recognition, escaping the immune system, so kind of immune evasion biology. This is another piece that, I mean, I would say really only in the past 10 years have we really learned about how it is that cancers build themselves using building blocks that allow them to escape the immune system. They have to do it. I mean, in other words, like, if they became sufficiently different from normal cells through mutations, right, they become increasingly likely, not 100% certain, but over time, more and more likely to be seen by the immune system. And so having mechanisms to basically escape surveillance are critical. And then you might ask, well, are there cells in the body that actually know how to do that actually know how to shut down branches of the immune system? Yes, absolutely. There are immune privileged sites, and there are immune cells that shut down other immune cells. So that's another part of the blueprint. Right.
I think, and I've said this before, I think we don't pat ourselves on the back, and thank our immune systems enough, because throughout your lifetime, your immune system is doing its job. It's going in and says, hey, you're not doing what you're supposed to. You're out of order. You're out of line. You get chopped, you get laid off. And that's how these cells are being destroyed. And every now and then, somehow a cancer cell or even a precancer cell gets tools to all of a sudden behave in a way it's not supposed to, and had the ability to not be seen, almost like a Harry Potter cloak of sorts. Yep. So to understand this correctly, and so anyone listening understands, a melanocyte in and of itself has done something it's not supposed to do. Is that correct? Because it's already left that neural area and gone somewhere where it's not supposed to be?
Well, I would say that it takes a certain, having the being programmed to have the zip code to get to the base of the epidermis, the kind of home of melanocytes. That's a developmental process. I mean, so I mentioned that briefly in passing, that in development, cells are doing lots of things that they're going to stop doing. Right. Once they differentiate and become kind of their adult version, if you will. Right. And that's very much true of melanocytes. They recover that ability. So in other words, they basically become capable of traveling again. And actually, maybe an important point to mention, just kind of before I forget about it, melanomas, that spread internally and become life-threatening. They are one of the most common causes of brain metastases, so brain involvement via spread. So breast cancer and lung cancer are the other two major cancer forms that will spread to the brain commonly. Well, advanced melanoma, metastatic melanoma, is far less common than breast cancer and lung cancer, far less common, but it gets to the brain very commonly, right? And it's a kind of a somewhat unanswered puzzle in our field to understand, well, is this because they came from the same cell population?
Almost like an ET come back home kind of thing. That sounds
terrible.
Exactly.
Exactly. That they know how to thrive in that environment. They know how to operate in that environment in a way that they used to know how to do in their primordial state.
Right, like they're indigenous, like that's where their roots are, and therefore, they have a proclivity to want to go back to the place that they came from. That's a very interesting concept. Now, talking about immune, surveillance or escaping immunity, this is what I think, and correct me if I'm wrong, but what I was taught is, really early on, I think the melanoma was first kind of suspected in the 1700s or 1800s, but it got to a point where people started observing that if you have a melanoma lesion, some kind of treatment was actually to rake it or scrape it, just to try to, not to cut it off, but to really inflame it. And that there were responses where you saw all of a sudden this lesion or potentially this cancer actually regress. Why? Because, in theory, you're literally stimulating inflammation and all of your immune cells to go and do something about it. And we're talking obviously like forever ago, but was that something that was seen in history? It's like, I don't know why, but when I scrape this thing and I can make it all angry, it seems to do better.
Yeah, no, that's true. That is in the deep history. Melanoma is, as I'm sure nearly everyone who's listening to this discussion knows, is it's a superficial cancer in its primary form. In nearly all cases, there are these kind of somewhat rare, more internal forms, if you will, where melanomas start there. But leave those aside. In general, it's superficial. And of course, there are other skin cancers that are superficial. But melanoma, just to remind folks that it's while it's not as common as squamous cell carcinoma and basal cell carcinoma, for example, both of those are more common than melanoma. Those are much, much less likely to travel. So the metastatic potential of melanoma is just off the charts compared to those cancers. So therefore, it just has a, quote unquote, pound for pound, far more life-threatening aspect to it. Any case, as you say, across the spectrum of superficial cancers, I'm probably bringing up those others because squamous cell carcinoma, for example, still to this day is treated with topical approaches that basically incite more inflammation, but where it's not just surgically removed, partly because people commonly have many of these lesions over time, and it becomes almost impossible to get ahead of them or stay on top of them with surgery alone. So borrowing from the same concept that superficial cancers in some instances could be basically just further inflamed, if you will, and that would be enough to get the immune system to kind of tip over the problem and just wholesale attack.
And by that you mean like freezing it, right? That's why you freeze.
Exactly.
That's what you're doing when you go into the dermatologist and they're freezing a squamous cell carcinoma of the skin. Of course, squamous cell can be other things. The whole reason is just to say, hey, make it really, not angry, but really like calamity, so that everything comes and takes care of it.
That's right. And there's a certain way, or multiple ways actually, of killing cells that actually make them inflammatory, make them more visible to the immune system. And the idea is that if you can do that at a local site, that can actually spread elsewhere. And I should just mention, even though it's probably not on people's radar so much, when they think, if they've heard anything about kind of the revolution in terms of therapies that are relevant for melanoma, but now also for other cancers, they're probably thinking of drug therapies, get around the body, systemic therapies, as we call them. But it turns out there's actually been this sort of mini revolution of local therapies, like tumor-injected therapies, where basically patients might have disease beyond what can be injected, but just treating a single lesion can not only cause the immune system to vigorously attack and destroy that site, so no cutting out at all, just like putting immunologic drugs into lesions, but can actually incite immune attack of non-injected lesions. And this is something that, the first drug that was approved for this is referred to as TVEC for short. It's an FDA-approved drug for melanoma. But that has spawned this, explosion really in terms of, next generation strategies that are like that, that hopefully will ultimately be relevant for other cancers actually. but where you can't necessarily get a needle into every aspect of the disease. But if you can just, what I sometimes call, light off a stick of dynamite in one single tumor site, get the immune system to attack vigorously there, and then take the knowledge that it's gained systemically to attack other sites. That clearly has happened, at least in a subpopulation of patients who've received TVEC, and mounting evidence that some of the newer investigational therapies can do the same.
Interesting. So, as a spoiler alert, basically you're saying the concept is with TVEC, you don't have to go directly to the place of the cancer,
Right.
but just by stimulating, waking up the army and saying, hey, wake up, let's go attack this, colony of cancer cells right here. That, remember, immune cells always circulate. Obviously, they're occurring in your blood and soft tissue all the time. That can almost just nudge everybody and say, hey, go attack the people wearing the black mask and stuff. And therefore, in that circulation process, you actually can end up getting people away from that lesion just because everyone's amped up and circulated and saying, let's go get this bread. And then they start attacking other places. That's a very comforting thing because it avoids needing systemic, therapies that will kind of, be toxic to all of your tissues and all that. You avoid all of that with this strategy.
Yep. Yeah, there's two issues here, and I think maybe this kind of previews a little bit what we'll talk about in terms of the systemically administered drugs. There's two concepts. One is that there's kind of a tipping point phenomenon. There's mounting a tumor clearing, elimination type immune response. And at what point do you reach that threshold, right? So just think of just a kind of a, literally a, it's sort of a chemistry concept of activation energy, that you get over the hump and basically the immune system then can sort of take care of things. Can we do that most effectively, more commonly effectively at a single site, where we can actually kind of essentially manipulate the immune system in multiple ways, or in a very kind of powerful way at a single site? Or can we get there with multiple drugs systemically? In other words, can we achieve the same phenomenon systemically? And to your point, let's keep an eye on both sides of the equation. It's not just a matter of getting the immune system motivated to attack the cancer. It's also to not have it attack normal parts of the body. And that's been the price we've paid, not with TVEC, but with some of the other drugs that we're going to talk about. That happens, right? And so what we've been learning, really through this process, because mouse experiments actually didn't do a great job of, anticipating this phenomenon. What we're learning is some of the same molecular switches that we're now targeting effectively with FDA-approved drugs. These same molecular switches are actually part of how the immune system, in its surveillance function, which you were mentioning, it's doing all day, every day, it actually has to differentiate between self and non-self. That's actually a constant problem or process. And it turns out that there are gas pedals and brakes, but some of those brakes on the immune cells are there to stop it from attacking normal tissues. And we've learned that by directly having drugs that very exquisitely only interfere with that one brake. That's all they do. And while they can have positive effects on the cancer, they can actually unleash the immune system against normal parts of the body.
So I'm gonna pull the rug now from underneath both of us and introduce that concept. What we are talking about now is saying, okay, there are cancers that have escaped the immune system and have that Harry Potter cloak or whatever, or a stop sign that says, don't attack me, immune system. We discovered what's called immunotherapy now, where we can actually knock off those stop signs or bind them up so they are no longer applying as the way that the cancer can escape surveillance. And basically, even though it's systemic therapy, we're liberating our immune cells and our lymphocytes to all of a sudden, it's like, I'm blind and I can see again. And suddenly they're not being told that they can't attack this cell. And then boom, they go and they're doing the job that that they've been doing their whole lives, but somehow have been tricked. And that trick has been basically taken from under them, or taken away from them, so they can go attack that cancer again. And we have two stop signs now, right? Or we've neutralized two stop signs that tumors have. CTLA4, right? Everyone's heard that, and PD1 or PDL1. Those are the two main ones we attack in melanoma.
Right, exactly. And then coming to a theater near you soon is LAG3. That's the third target in the same category. A positive phase 3 trial was reported now almost a year ago. And the FDA has been reviewing that data, and we anticipate, well, they've said they're going to make a decision within coming weeks, actually, as a firm sort of deadline. And given that the fact that there was a phase 3 trial that was positive for its primary endpoint, we expect that'll be, in melanoma, that's a combination of a PD-1 antibody plus a LAG-3 antibody versus PD-1 antibody alone. And we can unpack that a little bit. So now, I mean, leave aside the FDA approval for a moment. We hope and think that will come, but more to the point is just the evidence is there. I mean, a positive phase 3 trial. So we have 3 kind of validated levers, if you will, but they're all in the brake family, and the gas pedal and brake analogy, they're all on the brake side. But I just want to mention as we dive into this, that like people shouldn't lose sight of the fact that this immune evasion biology, we have every reason to believe it starts with the tumor cells. The tumor cells are the thing that are different, genetically different, than normal cells in the body. And to be able to persist and thrive ultimately as tumor cells, some of them, and melanoma is a fabulous example of this. They must figure out how to cloak themselves from the immune system. There's a lot to see there, is what I'll get into as we kind of unravel this story a little bit. So anyway, just think about it this way: you have tumor cells, and within the tumor cells, they have elaborated mechanisms to cloak themselves or defend themselves against the immune system. There's actually a kind of a variety of those mechanisms. So call those tumor cell intrinsic immune evasion mechanisms. We haven't yet figured out how to topple any of those yet, but that's a big area of research right now. So like look at, over the next 5 and 10 years, expect that progress will be made there. I'll just very briefly say that then adjacent to that, you've got, before the immune cells, you've got other cells in the so-called microenvironment, in the environment of the tumor that are not tumor cells and not immune cells. They get co-opted. They get co-opted in by the umor cells, right? So they bring them in for various reasons, but we have a lot of reason to believe, based on translational data, laboratory based data, that actually one of the functions they're doing is participating in this cloaking process. So and that's another area where, again, stay tuned, because there's multiple approaches that are being developed now, from preclinical now to become investigational therapies, trying to disrupt that axis and basically take off the mask. The category
to understand this correctly, you're saying that the tumor microenvironment essentially are cells that are not tumor cells, or your cells, but they've been literally hijacked or taken hostage and used to basically help or enable this neoplastic or cancerous process of the cancer in its location.
That's correct. Sometimes even feeding tumor cells directly what they want in terms of growth factors and sort of growth signals, if you will, and anti-death signals and the like. But actually, like fibroblasts are just a nice example. They're all over the body, but certain cancers recruit in tons of them, and we have more and more evidence to suggest that actually part of the function that they're playing is this cloaking mechanism as it pertains to the immune system. But anyway,
that's why pancreatic is so hard to treat, is because they really are the gurus of monopolizing that environment.
And we have precisely. I mean, the ratio of fibroblasts to cancer cells is actually off the charts in that instance. We haven't proven, because we don't have effective cancer fibroblast directed treatments yet. There's some in the works, but nothing yet, nearing the finish line. And the point then being that, once we have an example of that, like a drug that actually targets that population, and we see, inrush of immune cells and potentially the ability to combine with things like PD-1 and, kind of clear tumors away, well, then we'll have validation that all this, kind of model system evidence is relevant to humans. But the models certainly suggest that. Anyway, I'm just quickly kind of hitting those what I call compartments, because what we're going to be focusing on are the immune cells themselves, like drugs that target gas pedals and brakes on immune cells, and really I would actually go further and say just about all the success so far in melanoma and other cancers, in terms of immunotherapy, drug immunotherapy advance, has been focused on T cells. The final cell population in the cascade of immune recognition and response, the ones that do the killing. It's figuring out the gas pedals and brakes on those cells and figuring out how to drug those. That's been, when people have read anything, I mean, whether it's, New York Times, Wall Street Journal, or New England Journal of Medicine, when they hear about immunotherapy revolution, that's what they're reading about, really, is these T cell gas pedal / brake directed drugs.
Right. And there's one example of that. If anyone's heard the term CAR T therapy, that's, used in blood cancers, lymphoma, and recently leukemia. What they're doing is they're literally taking out your lymphocytes, right? T therapy, CAR T. And then they take a piece of like the tumor and say, hey, this is your blueprint to say, go look for this guy. I know you're doing your job, you're doing great, but let me give you a little help. And they manufacture these lymphocytes, give them back to you. And suddenly these kind of like, almost like bionic now, lymphocytes can hone in and have amazing responses in these blood cancers. But The interesting thing about melanoma, and you always think about chemotherapy with cancer treatment, but we've never classically had any success with just the chemotherapy part. You don't use carboplatin and cisplatin and Taxol and all these things you may or may not have heard with people getting other cancer types. And in fact, in melanoma, just to give you an idea of how important immunity and immune cells are, we actually injected, and still do in some places in the country, high levels of the signal that your body gives off when it's under like really bad infection or it's all calamity, you're in the ICU. It's called IL-2, interleukin. All of our interleukins say, fever, blood vessel dilation. I mean, it's chaos. And we inject them in high doses with people that have, metastatic melanoma. And sure enough, I mean, there are some cases where you get complete responses.
Yep.
But I hope anyone hearing that, listening, can really appreciate how much that immune system plays in and how people still do that in the country. And that's why that's why the immune focus has really been well known for a while.
Yeah.
But fortunately, everything changed in melanoma, like in the post-2000 era. Before that, if you had stage 4 melanoma, I mean, it was terrifying. It's like a glioblastoma today. And then came immune therapy. Those breaks, those T lymphocytes, those stop signs that changed the game. And now suddenly I can tell patients, you have about a 50% chance, correct me if I'm wrong, on responding to first line, which I know if you're listening to this, probably like 50% chance doesn't sound great at all. But honestly, like for something that was so scary, 50% is huge. And especially if you do respond, you could have up to a year and a half, 2 years. And I shouldn't say this, and you're probably going to slap me on the wrist, but potentially, indefinitely have a response, and usually a very robust one. And that's amazing.
Yeah, no, the durability of these responses is really off the charts compared to any of our standards that we set for chemotherapy drugs for various cancer types, and frankly, even the targeted therapies. I mean, some of the targeted therapies have been impactful in a way that's roughly in this realm. But basically, let me put it this way: if you mount an anti-tumor response that actually clears up evidence of the disease on scans in a patient who has metastatic disease, and the likelihood they're going to be alive. I'm sorry?
And half of the patients will. They'll mount with the standard first-line immune therapy, about 40-50% will mount.
We'll have a partial response or greater, but I'm talking about the greater part. So in other words, patients who have complete or near complete responses, so their scans normalize, those patients are exceedingly likely, greater than 90% likely, to live 5-10 years and counting, right? So we're super cautious about using the word cure in this situation, but those patients are off therapy, for years by the time 5 and 10 years are coming along. And general practice is to continue watching them closely. That's still what we do, at least presently. By closely, I mean every 6 months, sometimes out to every 12 months, but keeping an eye for the possibility that there could be hibernating cells. But my point is, these are remarkably durable responses, and even partial responses. So even when there's still something left on the scans, those typically last years. I mean, right? So we're talking, going from 10% response rates that were fairly transient with all the drugs that had been used for other cancer types, where we barely even considered those standard treatments. I mean, the FDA really, essentially said to us in the melanoma field, look, if you've got a new therapy in a clinical trial, and you're moving on to phase 3 trial, and you're thinking, what should I compare it to? You can compare it to these 10% response rate chemo drugs or not. In other words, like literally placebo control, in the decade of the 2000s, let's say, up to that late, was considered still to be, quote unquote, scientifically appropriate, although obviously challenging to contemplate from a doctor and patient perspective. In any case, that's how close to zero we were. And so we've taken this huge leap. So, I mean, let me just put some numbers on it, just so people have a kind of way of thinking about this kind of quantum step here. So PD-1 monotherapy, that's the big moment in the melanoma field, but we can chat if you like about some of the adjacent areas where it's equally impactful, like in melanoma, because there's some common threads there as to why. 40% response rate in the treatment naive metastatic setting with PD-1 monotherapy. Ballpark 5% legitimately concerning severe autoimmune toxicity risk, but 40% response rate, and those responses are durable. But like I said, let's say somewhere in the realm of 15 to 20% of patients are apparently permanent. Okay, of the original.
That's insane.
It's astounding. I mean, it's absolutely astounding. So we didn't know that.
Chemo drug with just an immune system liberator, basically.
Yes,
That's just wild.
Where frankly, I mean, as the general rule of thumb that I give to most of my patients is, 60% of patients actually don't notice anything, don't have side effects at all.
Oh yeah, that's what I always say.
I mean, 60, like, nothing.
Not
Now,
even 50. I'm like, most don't have a thing.
right, in many other cancers, PD-1 antibodies are given with other treatments, as you well know, more common cancers. Classical chemotherapy drugs is a good example, and those drugs obviously do have a bit of a burden in terms of toxicity. But melanoma, that's not the case, because chemotherapy drugs are so weak. We skipped essentially right over those, and PD-1 antibody monotherapy. I mean, it was actually compared to head-to-head chemotherapy in one large phase 3 trial, but it just blew it away as a comparator. And so PD-1 monotherapy in the frontline setting, that in the year 2014, that became our kind of bedrock standard. Now, interestingly, CTLA-4, ipilimumab, is the one marketed drug in that class. That came before. I mean, that was FDA approved in 2011 in melanoma as the first indication, and still to this day, the only cancer for which there's single agent evidence of sufficient efficacy to lead to FDA approval. That has a 10% response rate. Now, again, those turn out to be inordinately durable, right? So you'd say, well, 10% response rate, like what was the FDA thinking? Well, but these responses are like the vast majority of them are permanent. Okay. Right. So, and a phase 3 trial that, head to head against a comparator demonstrated that patients live longer, right? So like there was just no question. The FDA, like that's kind of their ultimate question is if you can do that, you've got
still a 1 in 10 chance of living or passing away, unfortunately.
For sure. So I mean, obviously, you can imagine it would have been more challenging for CTLA-4 antibodies to make it to market if PD-1 already existed, but PD-1 wasn't there yet. Right. It was just in phase 1/2 at the time. So, any case, CTLA-4 came first with its 10% response rate. Then 3 years later, by FDA approval dates I'm giving you, 3 years later comes PD-1 with its 40% response rate. So, like, bam, like big jump up. Immediately, studies are done to combine the two. And now you start to see 55% response rates when you combine the two together. And again, those follow the same rules in terms of typically being durable and larger and larger portion being long term, as in 5+ years durable. Now the problem there, and this is what like precedes quick comments I'll make about LAG3. The problem is that PD-1 monotherapy is actually in general quite well tolerated / safe, with autoimmune or anti-self toxicity being the problem, gut, liver, skin being the 3 common sites, like graft versus host disease and transplant patients, same organ sites. Mm-hmm. Looks a lot the same, in fact, when you do biopsies of those sites. Any case, so PD-1 can do that in a legitimately severe way about 5% of the time. CTLA-4, 10% response rate, about a 10-15% chance of legitimately concerning severe toxicity, okay? You put them together, PD-1, CTLA-4 combination therapy, now you're up to about 50% concerning, like legitimately concerning severe toxicity.
And you mean like grade 3 and above?
Grade 3 or 4. I mean, it's like a mix of 3s and 4s, but like you think something you have to do something about is my point. You can't just ignore it. And so, and in fact, you really have to do something in some cases, or it'll become life threatening. So what I'm getting at is, for as exhilarating as the sort of swing up was in terms of efficacy and long-term benefit and so on, the toxicity from crossing those wires, PD-1, CTLA-4, that definitely gave us some pause in the field and felt like, well, do we have other ways of skinning this cat? I mean, can we basically learn from these successes and kind of apply other gas pedal / brake targeted drugs and get a similar result without the downside, right? And that's what PD-1 LAG3 looks like. Admittedly, the data is not as mature, but it's a decent, a large phase 3 trial that was conducted clearly shows PD-1 LAG3 better than PD-1. Of course, people might be wondering, well, what about PD-1 LAG3 versus PD-1 CTLA-4? That other, now, by the way, in 2016, FDA approved combination. Right. But we don't have head-to-head data, but it's unquestionably safer than PD-1 CTLA-4, and it demonstrates an incremental benefit that looks, ballpark similar. So I'm being quick about it, but my point is that like we've made these, inroads, but I just want to like really underscore that PD-1 monotherapy that was the big jump in efficacy. And at the cost of pretty modest toxicity, all things considered.
And that's what I hope anyone understands. The toxicities, unlike chemo, which actually works on your normal cells, may hurt the replication process, the ones that grow fastest, right? Your hair, your gut, you get nausea, you get hair loss. That's actually working on the cell. In this case, your hyped up, or not even hyped up, but really liberated immune system, sometimes the immune therapies actually knock off or block the stop signs on your normal cells. So then your poor lymphocytes, can't blame them. They're doing what they're supposed to do. It's blacked up, and then they go and attack it. But usually in these cases, that's when you give high dose steroids because steroids wipe away lymphocytes. That's when you hear about, well, do we do steroids in viruses or not? Is it going to make them immune compromised? That's what they're talking about. They're talking about those antibodies, B cells, and lymphocytes. Now, one story that I hope anyone listening can appreciate that really illustrates this is I had a Marine. He was like a Vietnam vet and multiple, things for the country. And like I said, Marine, and I was told you never say former Marine. They're Marine for life, apparently, when you're a Marine. And riddled with melanoma. I mean, just like bulky, everything, like skin and bones. Gave him dual immune therapy. And, I thought it was a sarcoma, which anyone listening was a very aggressive thing. And there would have been nothing in that case. But gave him immune therapy. He did have locally in different places his lymphocytes attacking things. So much so, and I guess thank goodness he's a Marine, he actually had to get injections into his eyeball to help an immune reaction that was happening, behind near the retina. And then his thyroid, we had to replace thyroid and stuff. But by treating like locally so that we could still let this immune therapy work, complete response. The guy has literally no visible disease on his PET scan. And now with what you said, could be that way for years and years and years. And then you support him through and you hope to not wipe away the treatment because we know for sure that stage 4 melanoma would have been devastating. The flip side is I had a patient that was in the ICU, 36 years old, and had really bad melanoma mets in his lungs, had young children, absolutely wanted to live. And I was trying very hard to convince them to do the, intubation, whatever we had to do to get the immune therapy in. I'm like, this is not like a 5% chance of working. The odds are so high. His young children, mom had passed away. And I wasn't able to convince, and I think a lot of the talks basically, told him, well, you have metastatic cancer, it's incurable, and then we never even got to put it in. So there's many circumstances when it's not appropriate to treat when somebody's in the critical care, no doubt about it. I think oncology has a bad history, some justified, some not, but there are treatments like a small cell. My wife had, she's also an oncologist, and she was put hospice, but a small cell is another one. You treat when you know things are sensitive and have an extremely high chance of working, and if you don't treat, that the chance of death is very high. Then talking to the oncologist matters.
And in this case, we're talking about therapies. I mean, non-oncologists, generally think of all the treatments we give as impairing the immune system. Well, this is the opposite. This is impair the immune system. So, like, if someone's wrestling with issues, comorbid, or severe ones, like you said, even in the ICU, it's not that they're going to now be vulnerable to infection as a consequence of giving them these drugs. It's not the case. So, no, it's true. And I mean, there is I'll just a couple things to mention, that we haven't touched on. One is that there is in some patients, there can be a point of, if you will, no return, meaning where cancer has evolved in such a way and the immune system engagement of it has weakened in such a way that in certain people who have really advanced cases here, focusing on melanoma, where the likelihood of getting a response, unfortunately, is just massively lower than it might have been, had the cancer been discovered, 3-4 months before, let's say. So there's definitely, in the data, it's pretty clear that many of these patients are not included in clinical trials. So some of what I'm reflecting is, attempts in clinical practice post-approval to try to rein back in, the most advanced cases that are found, in such a late stage. But applied earlier and earlier, the odds of getting durable response, actually, the good news there is that it climbs higher and higher to the point that, many cases of metastatic melanoma are found, with a single organ involved, lungs the most common. And that's, the response rate is extraordinarily high, 75% easily for PD-1 CTLA-4 combination therapy in lung-only metastatic melanoma, which is a reasonably common scenario. So one has to, kind of tailor their thinking and expectations a bit based on those circumstances. But that's just one issue. Oh, a couple quick points also. One thing that's really striking, when you give these drugs by themselves, meaning, again, no chemotherapy, or in the case of kidney cancer where VEGF targeted therapies are given with PD-1, that kind of complicates the picture that I'm about to describe. In melanoma, it's remarkably black and white in terms of who responds and who doesn't respond. Who gets a benefit and who doesn't respond and who doesn't. It becomes clear, even within 3 months, certainly by 6 months, it's absolutely clear. But the biology I'm getting in is really kind of fascinating here. It's really, the immune system goes right or it goes left. It's really black and white. And it makes it really tempting. And, my group and others in the field have been hammering away on this point of just understanding, okay, if it's so black and white, what determines that? What's kind of what's at that fork in the road, right? That basically isn't
Right.
being overcome, to mount an effective anti-tumor response. And can we sort of really focus our attention there biologically, to inform the development of these next
Right.
generation drugs that kind of start cranking up the response rates even higher. And just to be clear, back to that point that I made about tumor cell intrinsic mechanisms and this is where some customization or precision medicine is going to almost certainly have to come to bear. We just haven't been that way in this past 10 years. We've been kind of treating melanoma as though it's all one thing. Now, it's such a bad problem. I think it's defensible to just try throwing these therapies at everybody. But now, as we try to make the next wave of advance, I'm fairly convinced that we're going to actually have to kind of compartmentalize our thinking in terms of biological subsets.
I'm so glad you said that, because that's one thing that is one of the underlying, reasons for this podcast is when you talked about the high toxicities with dual immune therapy and how there's a new thing, LAG3, that looks like the toxicities are not as bad and yet the efficacy is same or greater.
Yeah.
You cannot discover that without a trial.
Yeah.
When you're talking about
Yes.
people that don't respond to the dual immune therapy, we're all excited here, 40, 50%, they're going to be durable. And then somebody says, well, what about me? Like I didn't respond. Now what? That's where it's a trial. And that's what you mean by precision medicine. What are the factors that we can identify or even theorize to say this is something that may make you not fall into the favorable side of the statistic, but we've located it, we think we have a drug for it, and let's see if we can, somehow incorporate that to then give you a better response. None of this could have been out. None of this, unless people enroll in trials. And that's why, I'm really proud with XCures that's, very close in that field with precision medicine and everything. Their whole purpose, and there's multiple AI companies, but the whole purpose overall overlying is let's get the education out there that this is where cancer treatment is going. It's precise. It takes all these age-old targets are bursting out everywhere in every disease process, and the only way to know about it is to go look for them. And then also for when we try in different places in the country and the world, don't you want to know for your mom or your dad, like there's somebody that had a similar mutation that escaped the ability for the first-line therapy to work, but this other drug is working for them? We have to collaborate together as a human race and with our consensus enemy, cancer, and be able to kind of bridge that gap as soon as possible. And the only way and you of all people know, the ridiculously amazing, innovative things you're studying and understand about melanoma, only way is to share what we know. And then, and when we know something or suspect something, have people enroll and be able to see if it works.
Yeah, no, I mean, well said. And no, I mean, we wouldn't be having this conversation today. You wouldn't want to be talking to me had it not been for clinical trial conduct and patients enlisting and partnering, and admittedly seeking a better outcome for themselves. But so much of that energy, having walked this walk with so many patients over my career, is to help the next wave of patients behind them. That are not. I don't mean I don't use the term generation that implies 25 years. No, I mean much sooner payoff than that for the field. It's absolutely. And we've seen those kinds of rapid cycles. So in the other side of my melanoma work, I focus on tumor cell intrinsic targeted therapy. BRAF targeted therapy is a thing. BRAF mutations were discovered in 2002, so almost at the dawn of my career. 50% of melanomas roughly have them. So, in any case, just a quick example here, just to amplify your point. It took us 7 years from the discovery of BRAF mutations to first see responses with the first bona fide BRAF inhibitor to finally be brought forward into clinical trials. So 7 year, we tried other things that we hoped would wrestle down BRAF. They didn't, in any case, and that was in clinical trials. So patients were, generous participants, partners in that process. Finally, in 2009, watershed moment, we enroll a cohort of patients on a phase 1 trial, 6 patients with BRAF mutant metastatic melanoma, all 6 of them respond. I mean, just bam, all in 1 month, one cohort of patients. It was we just knew we were in a different world. In any case, that the first of those drugs gets approved in 2011, same year that ipilimumab, the CTLA-4 antibody, gets approved. Right. 3 years later, a 2-drug regimen, BRAF inhibitor combined with a MEK inhibitor, gets FDA approved. How does that happen? Well, 2 reasons. One is clinical trial participation, but the other is patients generously participating in research in this other domain, which is to help us understand why therapies work and don't work. Right? So what I refer to as bedside to bench translational research, some people call that reverse translational research. Translational research more generally is fine. Whatever. The point is, even with FDA-approved therapies, we have a lot to learn. Even with PD-1 monotherapy in melanoma, approved now 8 years ago, we still have a lot to learn. And the point being that there's a variety of ways that patients can accelerate our understanding of cancer biology and advanced therapies. And my point is that in 2010/2011, like on the dawn of FDA approval of BRAF inhibitor monotherapy, patients who were participating in clinical trials were basically raising their hand saying, sure, I will undergo a tumor biopsy before I start treatment and again soon after, not to inform my own treatment, but to accelerate the research, right? And dozens of patients did that. We learned that the pathway was being basically reactivated, not by mutations in BRAF itself, new mutations in BRAF itself, which is a story in many other oncogene-targeted stories, but basically there are other mechanisms which we and my group and a handful of others described in this kind of shotgun rapid-fire fashion because of this, partnership with our patients. And my point is, in 2010, we were treating patients. Before the approval of BRAF inhibitor monotherapy by the FDA, we were already conducting a clinical trial combining two drugs. One basically added, a MEK inhibitor added to a BRAF inhibitor to overcome that resistance. And that worked. And so FDA approval of the two drug combination was 3 years after the monotherapy, right? Like
Wow.
That cycle time was completely unprecedented to go from like one drug regimen to a two drug regimen that overcomes resistance in a substantial way, like further improving overall survival.
Right.
And again, I just want to amplify the point that the partnership we have with our patients. I mean, I sometimes take this for granted because I live in the ivory tower, big academic medical center where so many of our patients are coming to us, knowing exactly that like this is a central thing that we do. Although not everyone is aware of that walking in the door, and we have to kind of get them up to speed on that aspect as well as simply what the treatment options are.
The thing that when I was a new oncologist I almost hated saying, because it sounded like I didn't know what I was talking about. I kept saying 50%, 50%, 50%, right? When I explained melanoma, I'm like 40 to 50% will, respond to immune therapy, dual therapy. 40 to 50, like about 50% will have a BRAF mutation. And I'm like, so if you progress, if you're in that, 50, 60% that can't respond to immune therapy, half of them will have a BRAF mutation and then be able to be a candidate for BRAF and plus MEK inhibition. And then after that, there's not much. So it is one of the processes, for whatever reason, is like 50, 50, 50, 50. It's mind-blowing what you just told me. I mean, the approval came, there's a big lag that happens when we know things are working in trials, but by the time they're approved. Yeah. And the only way we can like accommodate for that lag is to like already be looking at things, in multiplicity and really aggregating all of our knowledge and understanding together. If you have 30 people or 30,000 different organizations trying to get their own sample studies, that's a lot slower than having all 30,000 put together and then saying this works, this doesn't work, next thing. But that's what trials achieve. And there's no word I can say how revolutionary what we're doing today is compared to what it was 15 to 20 years ago.
Oh yeah.
Not shotgunning chemos and just like general like toxicity agents. We have identified so many things like, wow, why is this a tool in this cancer and this cancer and this cancer? And we know it goes down and makes it, we're identifying all these things that it's literally, we can't wait to go attack them. And that's why combination therapy is becoming so popular, because we realize cancer cells are smart. I mean, you would think that, but there's so many mechanisms that combining 2-3 different things that cancer is doing is our best chance at having that word durable responses. Yeah,
no, well, certainly the pace of progress has escalated enormously. I would maybe, I usually kind of think in kind of 5-year increments, because it's actually, if you just wind back the clock, let's go to 2015, 2010, 2005, 2000, there were unimaginable leaps, made at each of those times. When you look back of the previous 5 years, and then you go forward 5 more years and look back and be like, oh my, wow, even bigger, jump in terms of, therapeutic outcome progress. I don't mean just research insights, but actual benefit to patients. The melanoma has obviously been quite exemplary of this point. So much of that is driven by technology advances. Right? I mean, to molecular insight advances, but then like the digital advances as well in terms of actually being able to understand multidimensional data, wed that, with patient outcomes, so real kind of human data. And be able to kind of, tighten the learning cycle enormously. This is, let me just kind of finish with this point. I mean, that, what we're aiming for in the vast majority of cancers, is my kind of, typical, simple-minded way of thinking about this, is for drug therapy. Okay. 4-drug therapy that it produces deep and durable responses, allows patients to stop therapy, right? So I'm not talking about 4-drug therapy forever.
Right.
I mean, induction therapy, let's call it, for nearly all cancers. Now, people who are familiar with lymphoma treatment would say, "Oh yeah, we've been doing that for a while." And I'd say, yeah, that's right, because the old drugs, the ones, the pre-2000 drugs, when mixed and matched in certain lymphomas anyway, can actually achieve what I'm describing. Yeah. But you can add as many, you can put as many pre-2000 drugs together as you want in breast cancer, lung cancer, colon cancer, prostate cancer, melanoma, and you will not get meaningful increment in benefit, and you will get meaningful increments in toxicity. So I'm talking about targeted drugs, and everything we've talked about today is a targeted drug, whether it's an immune system targeted drug or tumor cell intrinsic targeted drug. But we need to get to match the complexity of cancer. We need to get to quadruple therapy, right? In nearly all cancers, we are, not even to step one. To step two. So let me put it this way: for about a third of cancers, we have, locked in, FDA approved targeted therapies that are based on a molecular insight. Okay,
right.
That's tumor cell intrinsic. 10% of cancer patients benefit from a PD-1 antibody in a heroic way. Okay, 10%. That's right. Some people would say, well, that's not that big a number. I'd say, well, no, that's just one type of drug. That's a really big number. That's actually huge, right? So a third of patients have a FDA approved so-called targeted therapy at the tumor cell intrinsic level. 10% of cancer patients get this big impact of PD-1 antibody therapy. But that leaves you the rest of cancer, right, for which we still have to find a foot in the door. We still have to find a primary vulnerability that produces an effect that's like what we just talked about, be it oncogene targeted therapy or PD-1. And then what I'm getting at is we've got to scale the combination. So when I was saying the vast majority before, combination therapy is relevant to quite a small percentage of cancer patients, like molecularly informed, biologically grounded combination therapy, 2-drug combination therapy, right? And I'm talking about the need to get to 4 drugs. So I'm just amplifying the point that we have biologic line of sight towards 3 and 4 drug combination regimens that we can reason based on
observations
or in more elaborate laboratory research. But talk about the need for clinical trial participation and partnership. I mean, we're never going to get there without, I would argue, doubling down on the clinical trial participation / collaboration model.
That's true. And I mean, there are people everywhere that are alive today, almost cured of things that were on trials for even drugs and regimens that failed. That's an important thing to know is actually one of Mika's friends, he was on a immune therapy vaccine trial for his stage 4 melanoma. They didn't pan out the data. It doesn't mean it didn't work completely. He actually was cured and is alive to this day. So the point is, it's so complicated. There's a lot to understand. Even and that tells you that even if trial drugs aren't approved, that there's obviously some mechanical thinking or observation in studies and research in the lab, whatever, that really do get us in the right direction. And then when you have that big hit, it happens. But I can't wait to discuss more. If we discuss even 1 year from today or 2 years from today, who knows what that conversation will sound like. I hope you're not telling me we need a dozen drugs. Hopefully we're at 4 and then we're good. But this has just been so insightful. I hope anyone that has had a real fear and was sensitized about the word cancer can hear this and say, okay, it sounds like we're headed in the right direction. It sounds like there's a lot more out there than what I understand as far as cancer, chemo, hair loss, and just poison until passing away. It's just so different for a lot of different cancer types, and the cancer types matter, and then the person matters, and all of that is targeted in precision therapy. We need to know about the stuff about the cancer. We need to know the stuff about you. We need to be able to isolate which of the things that are kind of the holdups on getting better responses, match them, crosswire them, and then one day, and I love this phrase, some experts say, we may not cure every cancer ever, but cancer may be something that we end up dying with and not die from. Just like shingles, HIV, whatever. You take medications, you don't have flares, you pass away with it, and just keep it under wraps, right? I mean, would you agree with that statement?
No, I totally agree. And I mean, I think that I align with that vision very much. But I want to add one more point to your, kind of heartening, kind of synthesis here, which is that, it wasn't so long ago that, a dear colleague of mine, well-known figure in the field, made the comment. He was not a melanoma physician or specialist. It made the comment publicly and repeatedly that melanoma gave cancer a bad name. I mean, in other words, it was just one of those cancers that if you were diagnosed in its advanced form, right, that many people, were informed of the treatment options as bad as they were, as ineffective as they were, and chose no therapy, and and basically sort of and that was that. And unfortunately, we still have a couple cancer types that are kind of in that realm, right,
Yeah.
where we just we haven't really lifted off the ground in a very meaningful way. I'm not saying that there's no treatment options even for those, but anyway, my point is that melanoma was certainly one of the last cancer types that anyone would have thought that scientific advances would cause this fundamental leapfrogging. I mean, where we've had this quantum step up, where patients with far advanced and just again, what would have been just horrifically terrifying findings on scan, you get a biopsy result back and you see it's melanoma, and you say, hey, like, we're back in the game. I mean,
yes.
Exactly. I mean, in the way that people have said about lymphoma for for quite a long time.
Right.
And so what I'm getting at is, if it's possible in melanoma, I mean, I say this as a melanoma doctor, but many of my colleagues who are not melanoma specialists say this to me also. If it's possible in melanoma, then it's possible in every cancer, right? That we will have these leapfrog moments, and I think for those who've had a family member with cancer, or who themselves have been diagnosed with cancer and are thinking, well, I'm unfortunately in the end of the spectrum where big advances haven't been made. What's going to happen? I mean, this is I'm certain of this over the coming years. Pick whatever number you want. 10 years, certainly out to 20 years. Is we're just going to keep seeing these big leapfrog moments happening in one cancer type or one molecular subtype of that spreads across 6 or 8 different cancers, right? Where the same therapy basically produces that leapfrog. PD-1's a bit like that, and so it's uneven, right? The progress, right? But it's big, and I mean, really, frankly, kind of magnificent. The individual gains that have been made. That's going to keep happening, and at a more accelerated rate. I mean, I think it's very, very clear that the windup for this is the technology advance that precedes therapeutic advances. It's coming. What we thought were undruggable targets are becoming druggable based on numerous types of chemistry advances. The complexity with which cells can be engineered, the way in which antibodies can latch onto 4 things instead of just 1. I mean, and deliver payloads. I mean,
chemo with it, and then
exactly, and not just chemo, but immunologic payloads on their back end. I mean, it's really right. The technology advances are astounding, and this again, it makes the prospect of participating in clinical trials just more and more obvious, frankly, right? Because of the access that one gets to these therapies, and there will always be, in the case of melanoma, we have these very, very good treatment options available to us now, but we can improve on them. And participating in a clinical trial, if you've just been diagnosed with melanoma, doesn't mean you're going to have the effective therapy withheld. No, you're going to have a new treatment added to it. Right. I mean, that's
a huge point. It's like we're giving you standard care, and we're doing something more to see if there's even a better chance of it happening, or less, toxicity.
Exactly.
And that was a great summary. I want to use what you said at the end, just all over my social media handles, because I need people. I really just, at the end of the day, want people to be desensitized a little bit to the scare with cancer, just realizing what's out there.
Yep.
To your point, there's the first tissue agnostic. What does that mean? That means we found something that doesn't matter what tumor it is. That if it has it, this drug works. I mean, that is unheard of. NTRK, still waiting to find one. But NTRK, right? So and that's where we're at. And like you said, PD-1, PD-L1, same thing. We know that that's a tool that a lot of things use. How do we make it more specific for tumor type? And it's the sky's the limit. This has been so awesome. I'm so grateful for you taking the time to be here. And I hope, they'll have to listen to you a couple of times. I talk fast, and you're one of the few people that talks even faster, but probably tenfold. But I really appreciate all the insight, and I hope to have you back. And thank you for everything you're doing for everyone, especially my wife, blonde, blue eyes, higher chance of melanoma in that industry, just because, it's something that we all fear, but have made huge gains on.
Yeah, my pleasure. I really enjoyed the conversation.